Hello everyone, welcome to Physiotherapy in Lesotho, www.physioinlesotho.ch. You are listening to a podcast from one of our physio workshop in Lesotho. Your speaker is Thuso, W. Fasser, a qualified physiotherapist.
So let's go in now into the topic of the mobilization of peripheral joints. Very often we see patients, they have a stiff joint. Let's say they had a POP of the lower limb because they had a broken ankle, or maybe tibia was broken, or even worse, tibia and fibula was broken. They had POP. So the POP maybe was blocking the ankle joint or was blocking even both knee and ankle joint. The normal consequence of immobilization is stiffness of the joint, is loss of movement. When we immobilize, we will have stiffness on the joint. There is another effect of this immobilization. Patient will lose power, muscle power. So we will see the muscle, they are no longer thick and well trained, they are atrophic, we call it. There is less muscle. The fibers are still the same, but they are less thick, they are less strong. So we have the immobilization, the incapacity to mobilize. Then we have the weakness of the muscle. Immobilization has another effect. The nerves are no longer trained to activate the muscles. We call that recruitment, the neuromuscular recruitment. That means the brain, the spinal cord, the nerves, they are no longer used to use these muscles. So they get somehow disactive. It's not so easy for them to activate them. Imagine these muscles for a month or 6 weeks are not working. So that nerve somehow is going into standby. Then to call up the nerve, hey nerve, wake up, work quickly, work a lot, do many things, work. The nerve is not listening to it. He has forgotten how to do. So this is an inhibition of recruitment, inhibition of neuromuscular activation. By training, that nerve wakes up and can do that work again. So immobilization, that means patient on POP, or maybe he is just in a back slap, is blocked like this, or maybe has external fixation, he cannot move the knee. That all has a consequence of immobilization. They are not mobile, so they will face stiffness, they will face loss of muscle, tone, muscle activity, muscle strength, and they will face inhibition of nerve recruitment, of inhibition of neuromuscular recruitment activation. So the muscle somehow forgets how to work. And these effects are not only the three main ones, there are other effects of immobilization. One important effect is tissue shortening. When we move, normally we stretch tissue, and tissue is flexible. Tissue means connective tissue, ligament, tendons, muscle, subcutaneous tissue, and the skin itself. When we move, all these tissues, they are regularly stretched and they are flexible. When there is immobilization, the patient is not stretching, so tissue will shorten. And shortening of tissue will make contractures. That means that we cannot extend or flex completely the joint. This is another effect of immobilization. Then there is another one. It is imperception. That means the patient cannot feel anymore properly that joint or the muscle or the movements there, because he was not using it. So somehow the brain turns a blind eye on it. A blind eye, that means the perception is not really good. They don't feel it really. So it's wonderful, you can say immobilization causes immobility, that they cannot move, this stiffness. And this inflexibility calls imperception. The logical consequence of immobilization is stiffness, inflexibility, and then imperception, not proper perception. When somebody is not really feeling nicely the joint, he won't be able to move it properly. Maybe you have done that experience. Maybe you are sitting somehow strange and then your leg starts to sleep. Then you stand up and your foot is asleep, okay? You cannot walk properly. You're somehow limping. This is because you are not feeling well. You don't feel the foot. It's somehow numb. It's a bit asleep. It's not a problem of the muscles. The muscles, they are not atrophic. The neuromuscular activation should be okay, but you don't feel it. Therefore, when there is imperception, that means reduced capacity to sense the joint and the movement, then the activation of the joint will be inhibited, will be less good. Let's call that the sensor-motor cycle. That means movement depends always as well on that what we sense. If we have good feeling in the joint, in the limb, movement is somehow easier to occur. If the perception is not strong enough, is not good, is of low quality, even movement is hampered. Is that understandable? So let's come back. Patient with POP facing 4-6 weeks of immobilization will face the consequence of immobilization. This is stiffness, muscle weakness, difficulty to activate the muscles, and imperception, and muscle and tissue shortening. Therefore today, wherever it is possible, the doctor will decide not to immobilize a patient, because we know of the problem of immobilization. But sometimes in a fracture, there is the only way to do is a POP, to do a good correction procedure, to do a reposition which is functionally good, and then applying a proper POP. When POP is there, we always have to think, for how long does that patient needs really the POP? And when is the time that maybe POP can be open and the patient just has a back slap and does already some tiny movements? If a POP is there for too long, the problems of immobilization become big. But we all know if the POP is there for too short time, probably the fracture can occur again, or there will be pathological bone healing. And this is a big problem. Therefore, it's always good to have enough immobilization, but not too long. The doctor will decide how long immobilization in POP has to be there. Today you have seen on a classical fracture here on the forearm, this very simple fracture. Somebody falls down, tries to help herself with the arm, and then cracks here radial, the head of radial, the bone here. We call it's a fracture in loco classico, it's that fracture here. Once there was a POP of 4 to 6 weeks, now maybe for 2 weeks and then a back slap. And gentle movements are already possible. If we have a patient who is careful of himself, he can do that. Results are much better. But if you have a fracture of the tibia, of course the POP has to be there for a longer time. If there is a fracture of the ankle, POP has to be there for at least 4 weeks, if not a little bit more, to stabilize nicely. So there is a proper time of POP, and then when POP is off, we start to move the joint. It is a standard physio referral that the patient, by removal of POP, is sent to physio. We show the patient how they can take care for the skin, because the skin is always a little bit, somehow after a month of POP you can see there is old skin, and maybe it's a little bit rough, the skin, so we show them how to treat the skin. And as the joint is not used to move, we help to do the first movements, and we show the exercise to the patient, which exercise the patient shall do immediately, and we teach him how much he can do on weight-bearing load on the joint. Sometimes it's just partial weight-bearing. Sometimes we say in a fracture of the forearm, just do simple movements at home, work a little bit, but don't carry a bag of water of 20 liters or bear a bag of cement around, things like this. So just be careful. We have to teach that to the patient, how much they can do weight bearing on that fracture side. If we can see the joint is really stiff, then it is helpful to do mobilization techniques. That means we apply passive movements. We call them mobilization techniques. We really work on the biomechanic of that joint so that the stiffness can ease and the patient can start to move. In this hand fracture, you have seen very often you give them a few exercises, you give them the task that they do a warm water bath with salt. After removal of fracture, I always say, just make a warm water bath with salt, rub the skin with something, and do exercise in that hand bath. You can take even some lengana, and you boil that water with lengana, you put some salt, and you rub even that lengana herb on the skin. You do somehow a peeling of that old skin with lengana herb, so it is disinfective, and you have the salt, you are just moving, scratching that skin, doing that type of peeling, and the patient is in the warm water and moving the joint. This is very helpful in the first few days, let's say 5 days after POP removal, so they can start. If it is an elbow, you just take the basin and you put the elbow in it and do the same treatment. If it's the ankle, you do the same. On the knee, it's difficult to do this water bath, so you just rub warm lengana salt water on the knee, you rub the skin, you do that peeling, and start the first exercises. So this salt and lengana water bath is so helpful in the first few days. Remember, lengana is antiseptic, it is antiviral, and it is antimycotic. It is wonderful, it's very potent, and after a month of not washing the skin, of course, it is a little bit dirty. So we do that washing, and it helps as well the circulation and to relax the muscle and to start to move. So, yes.
Lengana is
Lengana is antiseptic, antiviral, and antimycotic, antifungal. This lengana herb, as we know all together, it's called Artemisia afra, is such a potent medicinal plant, and we can use it for so many purposes. You remember our teaching about Artemisia. So I use it in these cases as well. So when POP is off and we see it is a stiff joint, first I do this treatment to that stiff joint. Then I evaluate, is the joint painful? That means much pain. Or is the joint painful and stiff? That means quite a lot of pain and stiff. Or is the pain little or nearly nothing, but the joint is stiff, 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 stiff. You can have these three type of situation after POP. You have the joint where pain is number one. The patient says, oh, it's so painful, it's so painful. You cannot move because pain. So priority is pain. That means priority is pain relief. If we have the condition of major pain, priority is pain relief. We have to reduce pain. If the condition is a stiff and painful joint, that means it's bearable pain and you can see stiffness. Then we have to say we have to do pain relief and we have to tackle the stiffness, to treat stiffness. You see, in a very painful joint, I'm not thinking of mobilizing it that the stiffness goes away. I think of helping to ease the pain. If it is a bearable pain and there is stiffness, I'm treating pain and stiffness. And if it's the third condition, that means major stiffness with irrelevant pain, then the priority is treating stiffness, mobilizing the joint. Can you follow me? Yeah. So when I assess this patient, I ask myself, which condition is it? Is it number one, major pain? Is it number two, bearable pain and stiffness? Or is it number three, major stiffness and irrelevant pain? Then I will say, okay, this is a very painful joint. Now I do a pain treatment. Or I can see this is painful stiff joint, so I will do pain treatment and gentle mobilization. If it is very stiff joint, irrelevant pain, I will do mobilization only. You see, it gets easy. What you see very often is number two, condition number two, pain and stiffness. That means on the beginning we work with gentle exercise and we do gentle passive mobilization of the joint. We are not forcing, we are doing it gentle, without forcing. And I give to the patient gentle exercise to do at home. Now we are going into that treatment. It is a principle whenever you work with a joint. First, treat the pain. If there is major pain, treat the pain. Second, work on soft tissue. Work on the soft tissue around the joint. And third, mobilize the joint. And then, to complete number 4, teach exercise which shall be done at home. We are treating pain, we are mobilizing, we are working on soft tissue, we are mobilizing, and then we give exercise. This is a standard pattern. Let me explain why we do like this. Why do I treat first pain? When there is major pain, the body somehow is paralyzing the muscles. If I have a huge knee pain, my muscles on the knee, they cannot work properly because the nerves are somehow inhibited. They slow down their activity because there is pain. It is a protective measurement of the body. If there is a lot of pain, the body says, oh, I better don't move the joint. So I just inhibit the nerves. And of course, the patient, when they have a lot of pain, they don't want to move the joint. So they immobilize themselves. Therefore, it is important to reduce pain that we come back to normal movement. How can I treat pain on a peripheral joint? If it is an acute pain, a strong pain, and if the skin condition allows, I put cold packs on it. I can make cold packs by putting a salt water towel into the fridge. Then it becomes very cold, and then I put that on that knee. Or if I'm somewhere in the village, there is no fridge, I just put a cold water towel on it. Maybe I put a bucket of water, cold water, outside of the house during the night. In the morning it's nicely cold, so that cold water, I use a towel, I put it into the cold water and I put that on the joint, and I repeat it and I repeat it many times. To reduce pain and using cold, you put the cold on the joint, and when the patient says, now it's no longer cold, change it. Don't wait until the joint becomes warm, because when there is pain, we want to cool down the joint. If it becomes warm, that maybe will increase the pain. So I say to the patient, now I put you that cold pack on your knee. Tell me when you feel it's no longer as cold as it was on the beginning. And then patient says, and I change it. Can you understand me?
Yes.
Oh, that's good. In that moment when we have a lot of pain, we are not massaging the knee itself in a way as we would massage it in a stiff joint. But very often you will see there is a swelling. The knee is swollen or the ankle is swollen. Therefore, I do edema treatment. And it's incredible to see when you have a painful joint and you do proximal, that means if it's the ankle, you will do it on the lower limb and on the upper limb. You do edema treatment, very soft lymph drainage strokes. It's a very gentle massage which activates the flow of the liquid. You do that and you will see pain reliefs. You are not massaging on the joint itself, but above the joint, so that liquid goes away, the swelling can reduce. I will show you then how we do that. So we do this, we call it orthopedic lymph drainage or orthopedic edema treatment. We reduce the swelling by increasing the flow in the lymph system. And this very often takes the pressure off the painful joint, and the patient feels a relief, and then they can feel better. There are some ointments which can help for pain. Methyl saline ointment is one of these ointments. In a very painful joint, we are using this one. If the joint is acute painful, I'm not using an ointment which is increasing circulation. Let's say we have this peri pine ointment for the joint pain of old people, for osteoarthritis. So these are joint pains due to deformity of the joint, destruction of the joint. It is not really an inflammation. So we have to heat up the tissue. We have to warm up the tissue. So we have this peri and pine resin ointment, which is very helpful. In acute pain, we don't use ointment which are increasing the circulation, which make the body warm. We use something which is cool. We can take maybe a little bit of alcohol, spirit, and just doing a bit spirit on the joint. We can prepare a natural medicine with spirit in it. Let's say we are using the pine resin and we make that spirit, it can be helpful to relieve pain. Even Lengana spirit can relieve pain. But the first tool we are using, because it's so cheap, we find it all over, is doing cold water application or that salt water towel putting in the fridge, using this one. So pain we're reducing with this type of intervention, and then of course with very gentle exercise. A little bit of exercise is necessary to reduce pain. Is there a question about the management of the painful joint? Okay, let's go into the management of the condition of a painful and stiff joint. When we have pain and stiffness, as I said, we will treat the pain, but then we start to mobilize the joint. Mobilization can be with active, gentle exercises. Let's say we have a broken wrist. We take it off from the POP. So the first exercise, I say to the patient, just bend and extend your wrist. Move it within the pain-free range. Movements in the pain-free range, they help to mobilize the joint. When you are not heading towards pain, the muscles are not limiting the movement. So you can do. Maybe he can turn a little bit. Supination, pronation. He can close the hand and he can open it. I tell the patient, do at least 1,000 pain-free movements a day with your wrist. So when we start to mobilize, we do pain-free movements. And do many of them. Many. Then I say, if it is problem of the hand, do household work. Do all that activity which you can do without creating pain. Experiment a bit. Maybe washing the dishes is already possible. Maybe making the bed is possible with both hands. Maybe preparing some food is possible. After 4 weeks of fracture here of radius, it's not possible that you carry a bag of 20 liters of water. You should not do that after a month because you can re-break it again. You should not go and dig in the garden. You should not go and maybe work as a builder and using the hammer, things like this. This is too early after 4 weeks. But household work you can do. So therefore I say, do already what you can do without creating pain. So we do pain-free movements, active movements to mobilize the joint. And then we, as the physiotherapy worker, we will do passive mobilization techniques. Passive mobilization techniques. Every joint has its own specific manual mobilization technique. I will show you the procedure, the proper maneuver to move the bones to create again the natural joint play. Joint play is the little movement between bones. The bones, they move among each other inside. Somehow they are loose and they allow movement. These are sharing movements, there are slippery movements, there are rolling movements, there are many little movements possible. It's always a puzzle of bones together, they have to move. So I will show you these joint play movements, we call them passive mobilization. We will do soft tissue treatment. That means I massage the muscles, I do stretching. We prepare the soft tissue that movement can take place. The joint cannot move when the muscle is too short. Or sometimes on the knee, you can see when the patient was in extension for a while, the kneecap is blocked, has adherence. Or the tissue above the kneecap is thickened, is in adherence. So the knee cannot bend because all the soft tissue is attached. When there is inflammation, when there was hematoma, it's like a glue which is fixing, attaching all the tissues together. So I have to mobilize tissue, to stretch tissue, to move the tissue so that the joint can be moved. So this is the movement work we do on the patient, the manual treatment. And then the last group of intervention, as we said, it is home exercise. We give a lot of exercise to the patient, these 1,000 pain-free movements a day, stretching exercises to the day, strengthening exercises, balance exercises. There are different types of exercises which the patient get to improve further what he has gained during the therapeutic session. It is not enough in the treatment of a stiff joint, stiff and painful joint. It's not enough what do we do during our treatment. The treatment will be intensified by the homework. Patient has to do exercise. So let's summarize. If we have the condition 2, painful and stiff knee, we will treat the pain. We will do soft tissue work, that all the soft tissue around the joint gets flexible and mobile. We will do specific mobilization techniques, manual techniques, and we will give home exercise, which are necessary for all these patients. This is the pattern we are following all the time. We are always working like this. Then we have the exception, condition 1, where you have major pain, you treat only pain, don't treat stiffness, it's too early. If you have the condition 3, major stiffness, don't waste time working on pain, work on stiffness. Do a lot of manual treatment, that means soft tissue treatment, mobilizations, and give them exercise. Little bearable pain is normal, no problem. You go straight ahead. You see now, it becomes easy. When I assess the patient, I ask myself, what is the condition? Is it number 1, major pain? Is it number 2, pain, bearable pain and stiffness? Or is number 3, major stiffness, irrelevant pain? Then I do the treatment with the consequent treatment for that. Such a treatment, sometimes with a hand, maybe in 5, 6, 7 treatments, we are through, things are going well, if there is not a complication. In a knee, after 6 weeks POP, it needs more time. Sometimes 15 treatments. Sometimes even 20 when it's very stiff. In an ankle, I think around 8 treatments we are really on a good point. Now, what are the complications of fractures? The complication is that the alignment is not good. You know, sometimes the bone is broken and then the alignment is not proper. The bone is not really good on it. Maybe it is a bit shortened, maybe it's oblique. The angle is not perfect. Therefore, I always touch the alignment and I consider, how is that alignment? Is it more or less normal? Then I can expect good function. If alignment is not proper, good function normally cannot come back. So we just can restore partial function. Here on the hand, when you can see the radius bone is a little bit oblique, you will see rotation will be blocked. Or on the elbow, when that bone here, the olecranon, is not really in place, it is distorted, you will see full extension is not possible. Or on the tibia, when the rotation angle of tibia itself, or if it is a bit oblique, if it is like this, you can see problems on the ankle, in the foot. So it depends as well of the alignment. That can be a problem. The alignment can be bad because reposition was not possible. It's not always possible to do it perfectly. Or POP was not correct or maybe not controlled and redone. Sometimes people, they place the POP, everything is okay, but patient is moving and so on, and after a week position is no longer good again, has to be controlled. It can be that the problem, and sometimes we don't know why, but then the alignment is not good. There is another problem which can occur in pathological bone healing. Let's remember, it is pseudoarthrosis. It is a pseudo joint. That means there where was the fracture line, there is no callus. It's not really regrowing the bone. So there is connective tissue between the two bone parts. On the fracture side, there is tissue. It's not really bone growing. So that means that bone is not stable. We can see that pseudo fracture here on humerus, on supracondylar fracture. There, it's just a mechanical sense there, mechanical reason. Easily you can have a pseudoarthrosis. That means the bone is not growing together. Therefore, the doctors know when there is a supracondylar fracture, we have to put in a POP for a bit longer, at least 6 weeks. Otherwise you can risk pseudoarthrosis there. And if there is that fracture not healing well, it's a disaster. It's really difficult to manage it, to reoperate it, to take a bit of spongiosa from the bone, from the hip, to putting in many weeks of POP. This is matata. So therefore, in these cases, I prefer they leave the POP for longer. I can deal later with the stiffness of the elbow joint. I prefer to mobilize a stiff elbow and not to have a flexible elbow with a pseudo fracture. So on the elbow we can see pseudo fracture. Here on the hand very rarely. And sometimes down on the knee you can see that as well, but it's not so frequent. Sometimes you have people, they, for some reason or another, the bone is not healing, or very slowly after a month, no callus. The bone healing is somehow very slow, it's not strong. This mainly comes because there is somewhere a malnutrition. Some minerals are missing in the body. Something on metabolism is not really good. Maybe the person is malnourished. Maybe there is another disease. Or maybe that person is not moving a lot outside, is not enough in the sunshine and so. So when we have this slow bone healing, remember, there is some help we can give them. There are simple recipes where they can have more calcium in the diet. There are some simple medicine, as we were talking already, with the egg and with lemon and so on. And then there is that wonderful herb of confrey, which you can make this package of this herb on the bony and the fracture side, which helps to heal bones. So we can somehow boost that slow bone healing process by natural remedies and by some adjustment in the daily diet. We can help that it grows better. When we have slow bone healing, that means we have to wait with the mobilization of the stiffness. We have to wait, otherwise we fracture the fracture again. So when we assess the patient, we have to assess as well, is this a proper bone healing or if it is a pathological bone healing? How can I understand that? I always control the fracture a bit. I move it very gentle and then I can feel, is it really stiff or is it somehow a little bit flexible? After 4 weeks, radius should not be flexible anymore. Or here on the elbow, it should not be flexible anymore. You should feel it stiff like a stick. Happy? Maybe the doctor made an X-ray and he will tell you, I can see there is a bit of bone healing, but it's not really proper. So the X-ray will show us as well, and then we know we shall do gentle exercise. The patient shall be careful that he's not breaking again. Interesting is, daily movement helps to heal bone, particularly the bones which need weight bearing, like tibia, fibula, even talus in the foot. and femur, this bone, they need a bit of compression to heal better. So as soon there is a bit of bone repair, we start with very gentle compression exercises we give them to give them the proper stabilization, proper stimulus due to compression. That means the bone receives a message, hey, be strong, be stronger, develop. So this little bony architecture inside of the bone, there are many fibers, it's a wonderful architecture inside of the bone. That architecture is reacting to that compression exercise and starts to prepare more of this architecture, more of these little beams inside of the bone. So the weight-bearing bones, they need compression to heal really good. So if there is a weak bone healing on tibia, after 4-6 weeks is still weak, we start with very gentle, controlled compression exercises which help to stimulate the bone growth. You see, these are the main principles around mobilizing a joint which was immobilized, the main things we are looking at during assessment. Now we will start with a simple joint to mobilize, and this is the ankle joint. The ankle joint, it's simple because it's handy, we can hold it easily. It is simple because anatomy and the upper ankle joint is not really difficult, it's not really complex, it's easy, and the soft tissue we can touch, we can even see all the muscles, and everything is just under the skin. We can hold, we can touch it easily, we can imagine anatomy, and we can feel the movements very good. The hip is much more inside, it is hidden in the tissue, it's not so easy to feel it nicely on the hip. Therefore I think it's a good way we start with the ankle joint. Upper ankle joint stiffness may be due to POP after malleolar fraction. We will do this practice together.